How are you? Same stuff, new day. Yeah, how are you?
Andrew,
Yes.
I'm going to put Stuart next to me.
Fuck that in the audience there.
No, Stuart Altman next to Dave between me and Dave.
I got you. Okay.
And then, actually, I'll put Stuart next to him. And then we should have to prepare the group presentation. And then, well, Dave is
So, Dr. Allman to David's left.
yeah,
Right. Right. Yeah.
I'm gonna have to watch the rest of it. Yeah.
Yeah.
Yeah. By text? Oh my gosh.
Yeah, I know. I take the take. So yeah, my wife works in New York for a couple, and then so it's easy.
I know you.
Yeah, he's coming on Tuesday, so a month. Yeah. Yeah. Brother and sister, right. Brother and sister, yeah. Yeah. You've been working with her. Yeah, no, she does. she's sort of our main team connection.
All right. Good afternoon, everyone. What a gorgeous day. Thank you so much for making it here to 50 Milk Street for HPC Advisory Council meeting. It's been our first Advisory Council meeting in 2018, and actually our first Advisory Council meeting in a while. So I'm really looking forward to sharing with all of you some updates on the work of the Health Policy Commission. And then, you know, as always, a great opportunity for discussion and questions and comments as we continue and think about our work for the rest of the year. So I think worthwhile we are, of course, live streaming the Advisory Council meeting. So I do think worth going around and just quickly introducing ourselves for the purposes of the webcast. Would ask all of you with your microphones, it's, you know, push to green, but give it just like a half of a second and then it will turn green. It's always a little complicated. So starting to my right.
Hi, I'm Colleen Elstermeyer, the HPC's Deputy Executive Director.
Matt Gallagher with the Home Care Alliance of Massachusetts.
I'm Scott Hart, I'm Vice President of Government Relations for Lady Health, sitting in for David Spack.
Cheryl Pescucci, I'm a nurse practitioner managing the chart team at JC Franklin.
Hi, Joyce Murphy, UMass Medical School.
John Irwin with the Conference of Boston Teaching Hospitals.
Paul Haddis from the Greater Boston Interfaith Organization. I apologize for having to leave a little bit before 1. It's not because I'm disappointed in the conversation necessarily, but I've got to go teach at medical school. So, thank you.
And Monica Sani, here on behalf of Assistant Secretary Tsai, myself.
Marcy Sindel, Chief Strategy Officer for AGS Health.
David May, Auto Mass Association of Behavioral Health System.
Chris Hager, Senior Fellow Health Policy at UMass Medical School.
Steve Walsh, Mass Health and Hospital Association.
Rich Buckley, AstraZeneca.
Norman Hahn on behalf of Moore Pellegrini.
Julie Bigdon, Executive Director, Mass Nurses Association.
Roger Patel, Boston Secretary.
Lucy McDonough, Phillips, here on behalf of Phillips Meeting.
J.D. Cheslock from the Massachusetts Business Roundtable.
I'm Mike Kelger from Blue Cross Blue Shield.
Brian Rossman, Healthcare for All.
Great, thank you again for being here. You have in front of you a pretty hefty folder, so I'm actually just going to kind of orient you to everything that's in it really quickly. We have a lot of gifts for our advisory council members today. So on the left-hand side of your folder, you can see a meeting notice and agenda. And behind that, there are a couple of different new reports and briefs from the Health Policy Commission. The first being a policy brief on ACOs, the first in the series about our certified ACO program. Right behind that, you'll see a brand new publication that we just came out with last week, which is Opportunities for Savings in Healthcare. This is a document that walks through 7 different scenarios in Massachusetts that would save close to $5 billion if we were able to achieve those targets. We'll talk a little bit more about what's in there. And then behind that, you'll see the 2017 cost trends report. On the right-hand side, you have the slide deck for today, for the presentation that I'll walk through. And then behind that is the accompanying chart pack to the cost trends report, which includes updates on a number of different topics, such as hospital utilization, post-acute care, and alternative methodology. So a lot of, we've been hard at work at the HPC since the last time I saw all of you. I'm going to give you some highlights from some of these documents, but wanted to make sure that you all had these reports. If you are interested, or if people in the public are interested, all of these reports are, of course, on our website and available online. So for today's agenda, what I planned to do was have just a brief executive director's report to just kind of give you some updates on the operations and upcoming events for the Health Policy Commission. And then really for the first half of the meeting, just give you some highlights of some of the work that we've been doing recently, and then happy to answer questions and engage in a discussion. But then really the second half of the meeting is kind of completely open for discussion with the advisory council, reflecting on some of the work that we've done, where are those priorities moving forward and that the council would recommend that the HPC focus on for the rest of the year. So with that, I will kind of just dive right into the presentation and the executive director's report. So the first thing that I wanted to just highlight for the advisory council is that at the end of last year and going into this year, we did do a little bit of a restructuring of how the HPC board is organized. When we first were established 5 years ago, we created 4 policy subcommittees for the board that would meet in between our big HPC board meetings to be able to dive deep onto specific topical areas and issues of importance. And these committees were really helpful, especially in the first couple of years when we were establishing a lot of new regulations and a lot of new processes, and allowed for a lot of opportunity to meet outside of the regular board structure. What we did at the end of this year and moving into this year is we decided to consolidate those 4 committees into 2 policy committees, really reflecting the 2 policy priority areas of the commission. So those you can see on slide 6, and this was a result of a little bit of a strategic planning process that we conducted and this council had weighed in on last year. We're really thinking about the 2 big policy priority areas for the commission being around market functioning and transparency, really thinking about how our market works and how we can improve the marketplace in healthcare. And the second being focused on the delivery and payment system and how we can promote a more coordinated, integrated delivery system with the proper types of financial incentives to reward the provision of value-based care. And if you think about the work of the commission, it really does fall very neatly into these kind of 2 big categories. Our review and monitoring market transactions, our review and monitoring cost trends certainly fits into the first bucket. Our role in certifying accountable care organizations and promoting behavioral health integration in patient-centered medical homes more neatly falls into the second committee, the second area. I won't walk through this again. This is things you've seen before in terms of how we think about our core strategies. But so slide number 8 shows kind of the first new committee moving forward, market oversight and transparency. And you can see here that in addition to the market changes, there's also our RPO program, our performance improvement plans, and research into specific topical areas will fall within this committee as chaired by David Cutler. And then the next new committee is Care Delivery Transformation, which includes our certification programs, our investment programs, our learning and dissemination programs, and that will be chaired by Marty Cohen. Would note also we do have a new board member at the HPC, Dr. Chris Kreider, joined us earlier this year. He is an appointee by the governor, filling the spot of a primary care physician on our board. So we're excited to have Chris Kreider joining us in this. So not much more to say on that. If there's questions, happy to entertain them, but just wanted to give an update that we did do a little bit of operational streamlining of the board moving into this year. And that will be kind of the structure that we think about our work moving forward. Next quick update for you is just on our agency's budget. So wanted to just let you know where we are in the state budget process. Last year we moved, this is I think our third year of being on budget in terms of a state appropriation that's set by the legislature and approved by the governor. The first 2 years we were level funded to the previous year's amount. This year we did request a small increase, just reflecting some base increases over time. And you can see both the governor and the House did recommend a small increase for us. So that is moving forward in I think a very positive way. I'm not anticipating any big issues there moving forward, but did want to at least highlight to the advisory council that continue to get great support from the governor and the legislature in terms of the operations of the HPC. Okay, nothing more necessarily to be said about that. Next big update is we just went through a process of setting the healthcare cost growth benchmark for 2019. Many of you in the room came and testified or offered written testimony into that process. This was the second year that we had the ability to potentially modify the benchmark. And as as a reminder, the default growth rate was 3.1%. We have the potential to modify that back up to 3.6%. And the board voted unanimously in March to stick to the 3.1, the more aggressive healthcare cost growth benchmark target. I would note on this previous slide, which is I think slide 14, you can see this was a summary of the testimony that we received, written and verbal, from organizations and their positions. Would note, while every organization that offered a formal opinion suggested that we stay at the 3.1%, I think it's also fair to say every one of those organizations, while recommending 3.1%, also highlighted some areas of concern that they would see on the horizon for the state's ability to meet that more aggressive target. And I won't go through all of them, but certainly I think a lot of consensus around keeping the urgency on healthcare cost containment while recognizing that there is a lot of dynamics, both state, federal, political, that may impact our ability to meet that target. But there was a unanimous vote, and the target for 2019 will be 3.1%. Marcy?
I should probably know this, but has anyone been put on a performance improvement plan since we started?
So we just completed, actually there was we kind of ran out of time at our last board meeting, but there was an announcement at that point that we had completed our review of the list that we got from CHIA in 2017, and the board did not elect to move forward with a performance improvement plan. So we have now gone through 2 cycles where we've gotten lists from CHIA of potential entities for a potential performance improvement plan. We have completed 2 of those annual cycles, and in both cases we have not recommended, the board did not recommend moving forward with a performance improvement plan. We are currently now in our 3rd cycle, so we have a new list from CHIA that we are currently in the process of reviewing, and so this will be another opportunity. I think the CHIA list that we have right now, I'm going to look to my staff, is for performance between 2014 and 2015. So there is a delay, of course, with the data in terms of when entities are referred to us. Yeah.
Is there any consideration of working with CHIA to change the criteria that they're using for selection? Because as you think about what impacts the benchmark, it's not only whether you grow on your base, it's whether your base grows, and they're not taking, I don't believe, whether the base grows for a high-priced entity into account. So you actually could have a change in the overall benchmark as a result of that. So I was just wondering if you thought about whether the methodology was in fact getting you what you were looking for.
So a few thoughts on the methodology. The methodology that CHIA uses to refer entities to the Health Policy Commission, confidentially refer entities, is based on their total medical expenditure performance. And they basically have two thresholds. One is if the organization, their TME grew faster than 3.6%, or kind of the benchmark at that time, then they're referred to us for a potential performance improvement plan. They did introduce, during the last cycle, a secondary pathway that takes into account the size of the organization and also can refer entities to us if they're non-health status adjusted TME grew at a significant rate. So the base standard is health status adjusted TME, and that can refer to us. So there are absolutely some limitations to this process, Marcy. One, we know that the basis upon which that they are referring entities to us is total medical expenditures as calculated by patients, HMO patients attributed to the primary care physicians of these organizations. So this is not looking at their kind of total experience. If we're looking at a subset of the patient population, HMO patients that are being attributed to the PCPs of that system. So entities that are referred to us are, by and large part, the primary care practice side of these health systems. So Mass General Hospital is not referred to us. I'm just using this as an example. It'd be the Partners Physician Network, or Atrius, or NEQA, or other physician sides of these organizations. Individual hospitals are not, for example, referred to us. So we do know that in some cases we are looking at a subpopulation of their experience when they're being referred to us. The other thing that we do know, and we've seen through this data, is that it is health status adjusted. And so many organizations we've been looking at the data, it does appear that many organizations, their patient populations are experiencing higher risk scores. And when the risk scores go up, that can adjust down their health status adjusted inflation. So we also look at the unadjusted TME to try to say, what's going on there. The benchmark, and sorry to kind of get into the weeds on this a little bit, but our performance as a state, whether we or not we hit the benchmark, that is not health status adjusted. That is just total expenditures. And so it is a little bit of a different lens when we're looking at individual organizations. And I think probably fair to say if your patient population got much sicker, that led to more expenditures, maybe we would think about that differently. The long answer to your question, Marcy, is that CHIA, I think, has definitely taken a little bit of viewpoint of referring entities to us and letting the Health Policy Commission do that more fulsome review of all of the different dynamics that are going on with an organization. So once they're referred to us, we are not looking just at that one experience. We are looking at the whole context of different factors. We'll look at what is their experience across all of their health plans. What is their experience? What is their position in the market? Are they high priced, low priced? Do they have a history of being low priced and maybe they're moving up in terms of a new contract? So when we conduct our reviews, it truly is a multifactorial examination of all of those different factors that weighs in favor of a performance improvement plan or not. And so it is a different process. CHIA's is kind of a black or white, you're either on the list or you're not. For us, we would look at all of those different factors, including the size of the organization. Okay, great. So a couple of upcoming public sessions that I want to make sure everyone's aware of. One, we did have a great listening session. I think some of you might have been here earlier today on shifting drug distribution channels, more commonly referred to as white bagging and brown bagging. Had a great almost 2-hour listening session with stakeholders this morning. But I have a couple of other upcoming events that I want to make sure you're all aware of. One in next week, we are hosting an event at the UMass Club for an event called Partnering to Address the Social Determinants of Health, What Works. So this event, we have an expert speaker coming to present. We're going to have a couple of panels and really wanted to highlight some of the work of organizations in Massachusetts that are truly putting in place new innovative ways of thinking about how the healthcare system can address the health-related social needs of complex patient populations. So we'll have kind of a panel that will talk kind of very practically about how different organizations are doing this, and a panel that will focus more on what are the types of policy changes that we'd like to see in order to encourage and to support organizations in moving this way. And so many of the organizations are grantees that we've had through the HPC's CHART program and our innovation program, as well as some other experts. So encourage you to, if you haven't already registered, registration is at capacity, but let us know and we'll put you on the Special Advisory Council waiting list if you'd like to attend. A second upcoming event is we are holding a public hearing on a new proposed regulation. This is a regulation around new patient appeals rights for risk patients of ACOs in Massachusetts. This is a requirement that was in Chapter 224 and that we have been processing and working on for some time. And would create a process where patients could appeal the decisions of their ACO provider, both within the ACO and then eventually through an external review process that would be administered by the Health Policy Commission. And so what are some of the things that patients might be appealing? That could be referrals within an ACO or outside of an ACO. It could be around a specific treatment plan at the ACO. So we do have, just a little bit of background, we do have these types of patient rights right now for insurance companies, and where insurance companies are making determinations about medical necessity, patients have the ability to appeal those decisions and eventually get an external appeal. This would be a new process for when providers are making those types of decisions around referrals or treatments, and that the patients would similarly have an opportunity to have an appeal and potentially an external review. This is, I think, fair to say, there are, to our knowledge, there are no other states that have implemented kind of at a statewide level new patient appeals for ACOs. So this is truly breaking some new ground, and so encourage you, if you are interested, to review the regulation. It's on our website, and give us some testimony and some feedback on that. We have a hearing and some testimony.
So one of the things I was concerned with, I did a presentation on ACOs in Washington the year before last. Because of the fragmentation we have, in order to do narrow networks, you have to have an adequate network. You have to have low cost or certainly competitive cost, but regional access. So what's happened is, and this is an observation on the new Medicaid ACOs, is that the resource is not available in that community or the person that you're being referred to. So what we're seeing in the South Shore is people are being sent to Boston, which is more expensive, when you have a competitive neighbor right there that can manage that service. So this whole, the AMA last year looked at this and we put a resolution forward for an appeals process, specifically what you're saying, but I see that as a major cost driver. So the presentation I made to the Southeast region last year dealt with conflicts, consolidation, and competition, and how it's a barrier to community health.
So I maybe want to just ask Lois, just to give a little bit more flavor on this particular topic. So the regulation does include some, when doing an external review and making a decision about whether to kind of override the ACO's decision, we do include some factors that the external review agency would take into account. I think geography and access to services was one of them, but maybe Lois can speak to some of the others.
One of the sort of key features of the new proposed regulation is the standard review. So when we would send out an appeal to an external review agency for an independent clinical professional to review, what standard should be applied. And the proposed reg has a standard that's different from medical necessity, which is what we use in the carrier context. And here we have proposed a standard which would be, is the requested treatment or service or particular provider more clinically beneficial for that patient? And that is a relatively high standard, but We also outline a number of different patient-specific features that need to be evaluated by that clinical third-party reviewer, such as, what are the barriers to access, particular concerns about the patient that whether it's linguistic barriers, geographic barriers, questions about timeliness, pre-existing relationships with other providers, all of those things that would go into making a very individualized decision for that patient.
Can you understand the health plan appeals process, right? Very clear prior authorization denied, you get a notice. How do you envision this working in real life if I'm a patient and I'm talking to my physician about different treatments? How am I going to know that they didn't refer me? How can you help understand how I would be aware of this and when the physician would be required to talk about this?
This is a great question, which is why we began this process with a kind of an interim guidance. And so for the past year and a half, risk-bearing provider organizations, effectively our commercial ACOs, have been operating under this guidance where we required that they provide notice to their patients in whatever manner they chose. And one of the difficulties, exactly as you've identified, is how do patients know they're in an ACO or that their provider is in a risk contract? And so the notice issue, and I think maybe Marcy can speak to this about how individual organizations, depending upon their structure, how they're organized, have implemented in different ways. And at a minimum, we've said that the notice should be accessible to patients. It's commercial patients for whom their provider is at risk in the regular place where they'd seek primary care and upon request. And so these, I think it will play out very differently depending upon the process the provider organization itself uses around making referrals. And as we've heard through our many engagements with the providers, there are many steps in locally before we get to an appeal, so that they hope and expect that the provider, that the PCP themselves will have direct detailed communications with the patient. If not, it could be escalated internally. But we have seen over the past year and a half a very limited number of these things that get to sort of a full internal grievance process, and we do anticipate probably fewer coming to us for external review.
And in the year and a half that we've been tracking this, the vast majority of these grievances have been around referrals, where a patient wanted to be referred to a different provider, maybe had a private relationship, and the ACO was saying, no, we're going to refer you in ACO, in network, for that type of service.
There's an inherent conflict in this, in that sometimes the referral is less about the cost and more about keeping the money in that network. So you may have 3 providers that are much lower cost locally that can provide that care, and that patient is sent to the higher cost center. But what happens is there's a phenomenon, sort of a halo effect, is that other patients who are not in the ACO also get sent to and get steered away from cost-effective care. So, an MRI is an example. If you do one at the hospital or in these networks, it's 3 times the cost that you can go to another outside referral. So we're aware of that as providers. If you can get stopped by the ACO or the system that you're working with if you do that.
I'd be interested if you're thinking about auditing some of the other providers, because clearly the more organized you are, the more of these that come forward, speaking as the system that has 2/3 of everything you've received. It's because we have a very centralized system, so we make it very obvious to our patients how to complain. We have a corporate complaints department that handles all of these, and so we're a strong internal grievance department because we want to make sure that we can do outstanding service recovery. So I just want to make sure that you're thinking about how do you get the numbers really up across the system, because I doubt it's that others are doing something differently, but they likely are reporting differently. I mean, I think that's a accurate observation, and we see this actually in the carrier space. So the extent to which in any given year we have a high number of grievances from one particular carrier, could mean that they're doing a better job about giving notice to their members about the fact that they can appeal. And so we're very cognizant of the differences, not only in size and structure, but in referral practices, actually, of the organizations. And so the volume of internal grievances, or down the road, the volume of external review requests we get, we have to sort of just factor that in.
Great. Paul?
Are we still on the item of public sessions, or are you, guys want to add a 3-second motion?
I got one more public session, then
Okay.
you can make your pitch. You don't know where this one's going. So the last save the date, I just did want to reflect to the advisory council. I know it's hard to believe, but yes, we have another healthcare cost trends hearings coming up this year, October 15th and 16th. And did want to just break a little bit of news with you today and let you know one of our expert speakers that will be giving a presentation at the cost trends hearings is Ashish Jha, who is a professor out of Harvard and just actually published a kind of a seminal piece in JAMA around the differences between the United States and the rest of the world in terms of why healthcare is so much more expensive in the United States. Basically, the punchline of the article was that it's the prices of those services. It's not necessarily the fact that we are utilizing a lot more services, but the cost and the price of those individual services is just much greater here than in other countries. So I think he'll, if you've had the opportunity to meet him or see him speak, he's quite engaging and will bring a great perspective to the cost trends hearings this year. All right, so that was the end of the upcoming public sessions. Dr. Haddis?
Thank you, and I do note that the statute says that we, the advisory council, are supposed to advise on the operations of the commissioners. I want to propose another idea for the potential of a public hearing, which is I know that at some point this summer you're going to complete a preliminary CMIR on the BI Leahy et al. Transaction, and then that normally leads to the parties having an opportunity to write a written response. My thought is if time could permit somehow that there could be an opportunity after the preliminary CMI or IR and after the parties respond, that any stakeholder, public matter, could write in initially based on the findings in your report or their response to offer commentary that might be of value to the HPC. And if the HPC from that written commentary says, some of the folks writing in here, we might even gain more from a little bit of a public hearing to ask some questions back and forth based on what they've written to us, that the commissioners and you might consider holding a hearing before the issuing of a CMIR. So that's my public hearing idea I wanted to request.
Thank you. We have gotten a request from GVIO as well, and something that is under consideration. I would just note, in the context of our past cost and market impact reviews, a public hearing has not been a part of our process. It's not contemplated in the statute, but
it's not prohibited either.
It is not prohibited. I don't know if anyone else has any other suggestions on public sessions or on that idea.
I think it's a good idea. So the question is, why not?
So just to give a little bit of context on our process, I think the cost and market impact review process is very well, it is very important that that work is conducted in an objective and data-driven way. And through the context of that, we engage with a lot of experts and do a lot of data analysis, and that really has been what drives our findings in terms of our reports. That being said, we do, through the course of any transactional review, talk to other market participants. And so we do talk to, for example, the health plans, we talk to competitor provider organizations. And so we do, through this process, solicit their both their kind of opinions, but also do they have data and information to provide to us that we can collect and hold confidentially that would help inform and strengthen our report. So we do have, through this process, while not through a public hearing, do reach out and connect with a wide variety of different market stakeholders who could help inform or provide concrete information to inform our report.
Yeah, okay, just one other addition. Just one other, there we go. Just one other point on that. No, I mean, I understand you collect the data from other stakeholders, confidential, et cetera, but, you know, speaking from my past experience, Medicare official, putting public data out there, letting public and other stakeholders analyze the data, send it back through a public comment period was very helpful. And I guess in this context, is there any harm in letting others testify, submit data through the public hearing process? And again, evidence-based, if folks want to blow off some steam, maybe that's their prerogative, but again, based on the decision on whatever additional evidence might come through that process, it's probably not a bad idea.
Marcy?
I mean, there have been 3 public hearings already, so as if you take the information that's been provided in those public hearings and written testimony into account. So I think unless somebody had new information to provide, I'm not sure what the value would be. All of this does cost money, and part of our mission is to save money for the healthcare system.
I wonder if I can just add one comment. The difference will be at that point, there'll be a preliminary report with your findings and potentially the parties able to give their gloss on it. That's different. It might stimulate other, reactions to that specifically. I'm not really looking for this just to be another open hearing and discussion, but really tied to help the commissioners craft a final report. That's why I think it really would make sense to try to do something like that, and a tweak to your process would be value adding in all sorts of ways.
I would just say that, and obviously I'm a self-interest party in this conversation, so I'm not going to get into in any kind of deep way, but I would say for the GON process, we had extensive public input and 3 locations, and in addition to that, hundreds of letters to the Department of Public Health through their process in terms of input. So there's been an ample opportunity. Plus, we've sought out folks throughout the system, stakeholders, other government officials. So it's been an extensive process, and we're following the rules of the road.
Any other perspectives on this? Mike?
So there's another topic for potential consideration outside the scope of a particular transaction, which I think affords the commission the opportunity to explore things in an educational way as opposed to within the confines of a statutory construct. I would suggest that the commission look at the prospects of vertical integration overall. It's a topic that's come up at past cost trends hearings. You've had expert witnesses on the topic that I think were quite good. And before we're in a position where we're looking at a particular fact scenario, it would be, I think, educational to the public and to stakeholders to explore the different issues that are interposed by vertical transaction as opposed to a horizontal.
All right, well, thank you, and as I said, Paul, that is something we're under consideration with the decision of the board. Great, so moving on to the next agenda topic, we did want to just show some highlights from some of the reports that you have in your packets, and then talk a little bit about if there are sparked any interest from you in terms of where we go next. So one just quick thing, now I'm on slide 22. We did take a little bit more of a revised approach to our cost trends report this year. In the past, what we've done is an annual report that has been upwards of 100 written pages, 10 to 12 fully written chapters examining different topical areas. Incredible depth of material. However, I think understanding how people process information these days, the 100-page written report is not the gold standard anymore. And so thinking about a revised approach that allows us to, yes, still have an annual report, but that is definitely much shorter and leans more heavily into visual and graphical as opposed to long written narrative chapters. So this year, our full cost trends report only includes 4 chapters, but then we accompany that with a fully a graphical chart pack that is just graphs with a little bit of text next to it that updates on some certain areas. And we're also moving much more into the area of online interactive content. And so we've really been piloting using Tableau, which is a kind of a data visualization tool, uploading a lot of data and allowing the public or stakeholders to manipulate that data in the ways that's most interesting to them. And so being able to toggle and to click to be able to do different filters and letting them use the data in order to help answer questions that they might find of interest. And so this is kind of a new foray for us. I think I would say Chia is also definitely moving in this direction of more online content, more interactive content, more data-heavy content. And so our website is going through a little bit of a transition right now. If you've been on it recently, you know that we're moving it to the new state government platform. But we do have some updated sites and encourage you guys to go online and look and play around with some of these different new data visualization tools. We also plan to not just do kind of one annual report, but really to kind of have different reports throughout the year. Smaller policy briefs, kind of in the 3 to 4 page area. And so really kind of try and diversify the way that we're communicating information to a lot of different audiences, and also being able to be nimble and timely in the information we're putting out. So as always, as you look through our materials and think about this, we're always open to suggestions and kind of what the next horizon here is. And I think this has been well received by the board and others in terms of this a little bit of this pivot from how we've traditionally done things, which I think is kind of a traditional government way that is that segment going away. So with that, this was our cost trends report this year. These were the 4 chapters: trends in spending, care delivery, hospital outpatient spending, provider organizations, performance variation. So I'm going to just do, a lot of these slides have already been in the public for a long time, so I'm not going to walk through all of the different findings in the report, but did want to just highlight a few of the most important ones. The first is, what has our performance been over the last couple of years relative to the benchmark? As you see on slide 24, we've been, on average, annual growth has been below the benchmark, although in some years it has exceeded that, and 3.55%, which has been very much a reversal from where Massachusetts was for the previous decade. And that's really reflected here on slide 25, which is just looking at commercial spending growth, so this private health insurance spending growth. And you can see that throughout the 2000s, Massachusetts in the orange line had commercial growth rates much faster and higher than the country. And really in 2012 to 2013, our trend line dipped way below the United States. And while it's been ticking up, it has still been much below the national rates. And that has created some significant amount of savings for Massachusetts in terms of what could have happened.
David, one quick. Do you have a sense of what you would suggest if somebody said, why do you think that is? What would cause that beyond the great work of the HPC?
There is a line dip right here in 2012 to 2013.
That wasn't a setup.
I think we are, very careful to say that there's some correlation there, whether there is a causality. I do think a couple of things. I do think it is. When asked about this in different events, I don't necessarily say this is the work of the HPC, but I think Chapter 224 did create an environment where providers and health plans and government were all able to focus really keenly on reducing healthcare spending growth. And so I don't think that's necessarily the HPC having done that, it's the marketplace that has done that. It's been the hard work of hospitals and health plans and providers and government, but all of those factors together. So I'm hard pressed to kind of think of one individual thing that has led to this, other than a lot of hard work by a lot of different organizations. And I do think the benchmark in and of itself creates an organizing principle that a lot of organizations could rally behind and say, we as an organization are going to really strive hard to make sure that we're hitting the benchmark. So I think probably more than anything, it's been the benchmark, but creating an environment. What would you say?
I would generally agree. And I would attribute it to the spurring of the conversation around cost and quality, right? So we now have a mutual goal to reach that then contributes to joint efforts along the way, and we can point to a metric. I also think it's, in my opinion, reflective of the right approach in terms of how to reach those goals, rather than in a more aggressive or penalty-based way. And so I would suggest that government does things well when they're a convener and a collaborator and sort of the entity that brings people together. And I do think that the HPC has been very effective at that role.
David, scan through. Does the staff HPC or GIA actually disaggregate this into pricing, volume, and residual, or you don't know that?
So we do get that information from our health plans, and so I think it's fair to say that even the small growth that we've had is primarily driven by price increases. So utilization has been low in terms of what we've seen. Now that's a little bit different than what I think the country has experienced, because I do think that there is an important factor here around the implementation of the Affordable Care Act and how that has maybe impacted some of the national spending growth. Whereas in Massachusetts, we were able to achieve basically full coverage in the 2006-2007 time period. So some of that literature around kind of unaddressed healthcare needs, and when people get health insurance, they use the system, may be a little bit of a different experience between us.
From 2003 to 16, generally speaking, if I heard you correctly, utilization has generally stayed flat, and most of the increase is attributable to pricing. Is that a fair summary from 13 to 16? I'm trying to put it
Yeah.
in the spot.
I think it's that price accounts for a greater proportion of the growth year to year than utilization.
David is our research and cost trends director. I don't know.
We did show some slides on this in the benchmark hearing. And I do think that 13 to 16 was historically a low price growth period, compared to earlier, compared to what we expect in the future. So I think it was about half and half price and utilization. And I will say we are working on some new analysis this year, really getting at the prices and the price growth, because it's difficult when you have the nature of healthcare changing. It's hard to come up with what is one price, what is the effective price. So we're going to drill down on that.
That's why you should always ask that.
Yeah. Well, the other pricing question that would be interesting to disaggregate is pricing of hospital care, physician care versus prescription drugs in particular, because some of the drug pricing is much harder to control at the state level.
And we didn't include the slide here, but in our cost trends report, we do break down the spending increases by category of service. And in the most recent year, the two areas that were the fastest growing categories were hospital outpatient spending and prescription drugs. Prescription drugs was number one, hospital outpatient was number two, in terms of kind of categories of service of where the spending growth was. So what this has meant in terms of kind of our trends related to the country is that we do see that we have narrowed our gap a little bit in terms of premiums, are higher than national average premiums from 2012 to 2016. The kind of gray brackets there show the difference between us and the United States, and that has been reduced a certain degree. reflective of our lower overall growth. There's also probably an underlying trend here too, where Massachusetts has increasingly been moving to high deductible health plans, I think now 1 in 5 products, 1 in 5 members in Massachusetts is in a high deductible health plan. So one of the key areas that we looked at, and just wanted to highlight a couple of slides in this area, was the hospital outpatient spending area. And so I always include this this graphical depiction because it helps really articulate the two different dynamics that we think about when we think about hospital outpatient. One is care that's being shifted from a hospital inpatient setting to a hospital outpatient setting, and that is cost savings. And certainly that has been a huge shift in our marketplace. We also think about another type of shift, where a shift of care from a physician's office or from a freestanding office is moving into and being delivered at a hospital outpatient setting. And that is cost additive. That care is, even though it can be absolutely the exact same service that's being provided in one setting or another, it'll be 2 to 3 times more expensive at a hospital outpatient department than in a community setting. So we really want to kind of dive deep on what's been going on here. And so this first slide on slide 28 is talking about that first shift from hospital inpatient to outpatient. And we looked at some surgical procedures here. I think these are 5 kind of high volume surgical procedures. And you can see there's been an incredible shift in the 2000s here, literally from kind of half and half to now the vast majority of these surgical procedures being delivered in a hospital outpatient setting. And there's a lot of benefits to this in terms of even the quality of care, patients being able to go home, and advances in the technology and care delivery patterns. And so this is, we see much more of these surgical types of procedures being shifted to the hospital outpatient setting. But when we look at some other types of less acute types of services that could be very commonly provided in a number of different settings, we see that there's huge spending differences and price differences between a community setting or a freestanding setting and a hospital outpatient. So this is just looking at an MRI, colonoscopy, and endoscopy. And you can see the percentage differences that occur whether it's depending on the setting of care. And so increasingly we've been seeing that some of this care is shifting into the hospital outpatient side. And part of that may be around acquisitions of practices and categorizing them as hospital outpatient. Some of this is, we know health systems are building hospital outpatient clinics and services. And so this is definitely an area that hospitals are moving into. This last slide on this particular topic compares us to the United States. And what this is looking at is just for routine physician office visits. So these are evaluation and management, which is kind of your basic doctor's visit. And what you can see on the left-hand side, if you just want to look at 2015, and this is Medicare because this is where we can get our most easiest national comparison. But in Medicare, 21% of our routine office visits were in a hospital outpatient setting, compared to about 10% for the rest of the country. So we, as a state, are generally just using more hospital outpatient settings than many other places in the country, and that is cost additive and spending additive to our healthcare system. Marcy?
This would be a good area for the cost trends hearings to really understand this, and as well as you were looking for other things to study. I think there's a lot of movement right now, the academic medical centers into the community, and understanding the impact of that on overall spend would be a great area to study.
Just to get back to slide 26 here on the premiums, one of the key messages of our testimony around benchmark was this notion that for employers and families, the real success metric is premium. So I'm just curious how you would categorize the relationship between the benchmark and this slide. Is it a direct line? Is it a dotted line? What is the relationship there?
gonna pass this one off to my expert here, David.
I mean, one thing to note about this slide is that our premiums were 11% higher than the US average in 2012. And by 2016, that gap is a little bit less. And that's just reflecting that slower growth we've had. You could also look at the premium growth year to year. And in the commercial sector, as we showed on that previous slide, commercial spending has been growing less than the benchmark rate. So that's a positive thing as well. But even then, these premiums are still, we're talking $20,000 a year for a family, and we are still higher than the US average. And that's only the average. There are, as I'm noting on the bottom, or in the previous slide, we've shown that for the highest 10% of premiums in the state, those costs are $29,000 or more. So at an absolute level, that's part of the whole point of the benchmark is to lower that growth so that over time it's absorbing a smaller and smaller portion, or at least a constant portion of income. I don't know if you had a different thought about it.
No, the way we think about it is that
the benchmark provides this downward pressure, right? And this is the outcome of that in terms of premiums, or at least this slow movement as you're sort of describing. But that is a positive outcome. There are probably some businesses which would go faster. But I just wanted to understand the relationship between the pressure of the benchmark and the outcome of the impact on premiums.
That is the key outcome, and we would love to have that actually be flat.
I think it's fair to say it's more of a dotted line than a direct line, because what goes into premiums includes other factors that in the benefit design and how it's constructed that may impact the premium level that is not kind of directly in the benchmark. But I would say, we got a lot of testimony at the benchmark modification hearing, and if John Hurst was here today, I'm sure he would have a lot to say on this. But that, depending, different employer sizes and groups may be experiencing different levels of premium growth. And so I think you're right in terms of how do people experience healthcare spending growth. They experience it through their premiums, their copays, and their deductibles. And so at the same time, I think there are some who are not feeling that relief that may come from looking at a slide like this and saying, oh, we're doing amazing, when they are seeing their premiums and copays and deductibles are continuing to increase. And I don't know, Mike, if you wanted to add anything as a health plan person here.
I would echo that. I'd also add, in addition to the different metrics that are contained within the measures, TME or THCE versus premiums. Premiums are a prospective filing, and the TME, THCE measures are a retrospective review. And so premiums are trended out for a future period of time, and are affected, for example, from the aging composition of the members in that group. But I would agree, generally, the dotted line influence is a good way to characterize it.
One thing I think would be interesting is to normalize the premium data by adding in the effect of the deductibles. Because I think you can see a premium go down, but if the deductibles are going up, and there's been tremendous cost shifting to patients, so I think that to a certain extent, some of that may be false data.
Yeah.
I just wonder, is there anything in Massachusetts minimum credible coverage that accounts for some portion of that difference between other states?
I don't want to speculate on that. I mean, I think, again, I'm not going to speak for John Hurst, but I think if he was here, he would argue that many of the mandates that are on the fully insured market have been cost additive in terms of the premium experience, but I don't want to validate that other than to just repeat that speculation. Okay, we're gonna keep moving. So one of the really new interesting things that we did in the cost trends report this year is around this provider provider organization performance variation. And so what we did here is this is all claims-based analysis. We attributed patients to primary care doctors out of the claims data. We did this both for HMO patients and for PPO patients. And then basically analyzed, rolled up all of those patients to primary care doctors, rolled those primary care doctors up into the major provider organizations in Massachusetts. And then we're able to kind of analyze what is the performance of these organizations for all of the members that are attributed to them. So this is the first time anyone has done this in Massachusetts, and so we were really excited about building this platform. Would note, I have a couple of slides here, but this is one of the areas where we did put a lot of the raw data up on our website in a Tableau file where you can click through and look at different organizations and see the differences. So this is just commercial members for the top 3 commercial health plans in Massachusetts. And this first slide is just looking at average per member per year spending. This is risk adjusted. And so what we did find though is that there is some significant variation among provider organizations in their per member per year spending. And what we did with the color coding here is categorize them by different system compositions. So whether they are AMC anchored, academic medical center anchored, physician led, teaching hospital, community hospital. And we started to see some interesting patterns here. I'll just go to the side and then I'll open it up. Interesting patterns relative to system composition. And one of the areas that we found that was really driving a lot of that variation between different organizations was hospital outpatient. So again, bringing back to the topic that we just talked about. And so here on the top, you can see hospital outpatient spending per member per year for these different organizations. And you can see, I think, a really clear trend that some of the AMC and teaching hospital anchored hospitals just have much more hospital outpatient spending than the physician-led provider organizations. Conversely, if you look at the bottom of the slide, we look at professional spending, and we did see that some of those physician-led organizations have higher professional spending. So there is some kind of clear trade-out effect here. Organizations spending a little bit more on the professional side versus hospital outpatient, but hospital outpatient was the biggest driver of overall variation. So this is kind of a new lens that we can look at different organizations and their kind of performance. And the last one that I'll just highlight here, we did a number of different ones. This was around percent of ED visits that were potentially avoidable. Here too, definitely some variation among organizations. Less of a clear pattern in terms of system composition. So we're really excited about this work, and we've already heard, interestingly, from some of the provider organizations, as you might imagine, were pretty interested in where they ranked relative to their peers. But in many cases, some of these organizations, they may have this information for themselves, and they may know what their rates are of avoidable ED use, but they may not know what their competitors' rates or what other market participants' rates are. So we had heard from some organizations that this really was enlightening for them, where they thought maybe they were doing really well on a specific category, and then once they saw where they ranked compared to some other organizations, said, oh, maybe we're not doing as well as we thought, or in some cases validating what the organizations thought about what their performance was. So this is the first year that we did this. I think we were, but we want to build off of this platform and use this as a platform for additional analysis. So with that little part of the cost trends, I know people have some opinions on this.
Yeah, thank you very much for doing this. I think it's about time that we represented more of the market than just the HMO market, which is not totally representative. And I just wanted to ask whether CHIA is now going to take on this methodology for all of their work rather than continuing to use the HMO only, which would be a shame.
I don't know is the answer. I think we've built a really good platform that can be replicated, because this is combining a couple of different data sets. This is your claims data with our registered provider organization data that rolls up into these organizations. And so I would hope that we could use this again. And we were able to, through our attribution methodology, which was very much consistent with kind of the market approach to patient attribution in the PPO space, we were able to attribute about, I want to say 85%, 80% of patients to a PCP. So that's a pretty good number.
How do you determine if percentage of ED visits potentially avoidable? That seems very over a third of the people going to an emergency room don't need to be going, if I'm reading this correctly.
Yes, so that's pretty consistent with national analyses in this area. So the analysis that we're using here is what's called the Billings algorithm. And what this does is it does look at claims data after the fact and says, categorizes visits into two main categories, avoidable visits into two main categories. One was the care something that if they had, they could have been treated in a primary care setting, or if they had been receiving care in a primary care setting, may not have exacerbated to the point of needing to go to the emergency department, as well as care that is truly just non-emergency care. So there is, this analysis has the benefit of happening after the fact and kind of categorizing these visits, but this has been generally consistent with national research.
One of the things is both perception and reality. So looking at the data from the new urgent care centers and so forth, a lot of those visits are during the day when the offices are open. So perception among patients is that the doctor is not available, and some of it is because the patient just basically can't get it. But many times that care is available. We are a cardiology group, and we cover all 5 different ACOs in our area. We have 24/7 coverage. We actually get the calls from the interns because the patients in our practice know that they can get a doctor admitted, but they can't get an intern. So that's a problem.
Yeah, there is absolutely a lot of some of these avoidable visits are patients who called their primary care doctor's office and maybe it doesn't have after-hours service, and in many cases they're getting referred to the emergency department and say, this is the place to go. There are a lot of alternative sites and there are a lot of practices that are moving towards more after-hours care. So, I think there's an opportunity here if we can connect patients to some better and more actionable information to actually help reduce some of this avoidable use.
There's actually a movement in direct care where we did an analysis 2 years ago that we could provide General Motors care for about a third of what they're spending. So there are actually some groups now approaching people like the Heart Union and so forth. For a small monthly fee, they're guaranteeing access to for those patients in that practice so they can be seen, keep them out of the ER. And I think that could be have a huge impact on this.
Steve, did you want to?
I just want to say, just a general comment, I know these are data for adults. Is there interest, feasibility, and pediatric data at some point, especially given what we know about utilization?
Yeah, we do have it. We only focused on adults here because it was more comparable. Some organizations have different proportions of kids, but we have that data and we would hope to also publish that.
Thanks, Stephen. So I'll make a couple of points that I've made in the past, but I applaud the work. I think you're moving absolutely in the right direction. I hope you can dig even deeper. And here's why. The avoidable ED visits is really a commercial for telemedicine, mobile hearing healthcare, and other reasons to get people to get seen in their home before they even make that choice to go to the ED. And it's something that I think we ought to be moving as fast as we possibly can to. And it seems that it's a little bit stuck, and I think it's something that we all agree to that are in the marketplace. The outpatient one is more complicated because hospital outpatient settings are competing with limited service clinics and ambulatory surgical centers that don't treat poor people. So I've said this here many times before. In 2006, when we did the access law, there were 0 limited service clinics, right? And there were many more hospitals than there are today. Now there are 194 outpatient setting limited service clinics of some sort, and most of them are turning away poor people that are on Medicare and Medicaid. So when we fix that collectively, as a Commonwealth. It will be easier in the outpatient setting to make these comparisons, but I think we ought to dig deeper into why hospitals are having to have outpatient settings, because those last few remaining commercial patients that are keeping their doors open so more people can walk to the emergency department are going to other places that don't treat people on mass health, and sending all the mass health patients back to the hospital. So it is I think it's a more complicated, and it is often a more complicated issue than the graph would have us believe.
One question, this is great work by this is awesome. The commercial population presumably includes self-insured folks,
Yes.
right?
Yes.
And then the second idea, avoidable admissions to hospitals, is that something that's also the program?
We have that, yeah.
Oh, we actually have it.
Some of that is in the cost of support. I mean, the variation is kind of similar. We're going to be doing more of that also in the future.
Which actually is a perfect segue to have a commercial about HPC data points. So HPC data points is what we have branded and termed these kind of online briefs that tend to include some of this new interactive data. So I won't walk through all of this other than say that we've issued 3 of these since the last time, just this year. The first was around quality measure misalignment in Massachusetts and the variation in quality measures that are being used in contracts. The second is basically a more robust version of what I just walked through, which is on this provider organization performance variation. The third, which we just released last Friday, we looked very specifically at in the Medicare claims data at imaging, medical imaging spending in Massachusetts. And we actually found that Massachusetts, we did a comparison to all other states. Massachusetts had the 4th highest spending on medical imaging compared to every other state. This was only on Medicare, 14% higher than the US average. And we also looked at the imaging costs compared again to whether this was in a hospital outpatient setting or any kind of a freestanding setting. And there was, we had a high rate of use in the facility setting, and there is very significant differences in the cost for imaging depending on the setting of when it's being delivered. But I would give a little note here. Upcoming issue number 8 is going to be focusing on urgent care centers in Massachusetts and their exploding growth that we've seen over the last 4 or 5 years. And so we'll give a little bit of a profile about what we know about the urgent care centers in Massachusetts, what their market looks like, what services they're providing, what patients they're seeing. So thank you, Steve, for teeing that up so perfectly. So a couple other things just to highlight for you. So that was all out of the cost trends report. The next big document that we did, which I won't spend much time on, is this kind of roadmap for up to $5 billion in savings. This was all modeling that we did in terms of as part of our benchmark hearing process. And so for each one of these, what we did was we modeled a target, a scenario that said if we were able to reduce hospital readmissions by X%, what does that mean in terms of total spending and savings to our healthcare system? So we looked at 7 different scenarios here, and you can see them all listed on this slide, which is slide 37. And for each one of these in the report, we have a target and then a projection. I'll show you one. So this was specifically around readmissions, and we said if we could reduce our readmissions rate by 20% by 2022 in 5 years, what would that savings accrue to? And it's over $1 billion in savings over a 5-year period of time. These are all, I would say, kind of hypothetical what-if scenarios, but I think, to achieve something like a 20% reduction in readmissions is not something that one can snap their fingers and just magically would happen. But I think the goal and the intent here was to provide some information in terms of what is the scope and scale of opportunities where we can continue to get savings and efficiencies out of our healthcare system. So some of these may be more related to specific legislative or policy changes that need to occur. Some of these are really just truly around the health system transformation journey that we're on. So happy to answer any questions kind of on this brief, but I encourage you guys to check this out. All right, seeing none. Did want to give a few more highlights to you and more on the care delivery transformation work. And so for that, I'm going to turn the microphone over to Kay Shea-Barrett, who is our Director of Policy for Care Delivery Transformation and Strategy, just to give you a couple updates on the care delivery side of the HPC's work.
Hi, good afternoon, everybody. Thank you. So a couple quick updates on our PCMH and ACO certification program, since there's been a lot of great conversation about ACOs, and it's a hot topic right now. For our PCMH program, which layers behavioral health integration to those standards on top of NCQA's PCMH program, we've been holding steady around 100 practices participating, with 80 fully certified as meeting 7 out of the 13 behavioral health integration criteria. So we're really proud of that, and we're doing some work to think about the future of that program, and so we'll be back to you at a future advisory council meeting with some more details on that. Moving to ACO certification, another plug for recent HPC publications. In your folder, you have our first profiles, our first policy brief. Profiles are not yet out. The policy brief on ACOs. And so the first one really is an overview of what are ACOs, what are the standards, who are they in Massachusetts. There are 17 health systems that participate in our program. Not all of them are hospital-led, some of them are community hospital-led, some of them are academic medical hospital-led, some of them are physician-led. And so we've moved from the certification part of the process to the analytic and transparency parts of the process. And so we're hoping to put out a series of briefs, ambitiously hoping to release one every 3 months. And so the first one is out and is in your binders, I mentioned. The second one is going to focus on population health management and some best practices around addressing social determinants of health and behavioral health through the ACO lens. And so the information that comes into us is confidential, and so we can't, unless the ACO allows us to give their name, we can't say, Atrius does exactly this, but we can say 15 out of 17 ACOs are doing this, or somebody has found some evidence of doing this to get a bit more transparency out in the market. So we're excited about this series. If you have feedback on it, we're really open for feedback and suggestions about the kinds of information that you all would find really useful for us to put out in the market from this program. So here is just another plug for Policy Brief 1, which is in your brief. I will note that Mass Health does require ACOs to be certified by the Health Policy Commission, although we do not just look at what they're doing for Mass Health. So we look at organizations at the highest level. So we look at what they're doing for their commercial risk business, their Medicare risk business, and their Mass Health risk business. So it's a all-payer look, and they have to meet our standards from an all-payer perspective, which is a unique element of our program. Marcy, did you want to say something?
Yeah, this is terrific. I sit together with Blue Cross and partners on the Healthcare Transformation Task Force, which is a national organization that's trying to move forward about value-based care. And so I send these as I get them along to them. But I'm wondering what else you're doing to help the rest of the country utilize this information to move forward, because I think it is, it would be a shame if others didn't learn from what we're doing.
Yeah, I think you've been so helpful at connecting us to some of these national ACO organizations. I have participated in a lot of them too. There's a kind of a lobbying organization for ACOs now called NACOS. Close enough. I'm hungry. I haven't eaten lunch yet. NACOS. And then there's the Healthcare Transformation Task Force. There's a California Learning Collaborative, ACLC. Yeah, so there's a lot of. It's great. I think people are really hungry for this kind of information about what are core competencies of ACOs and what are best practices. And so, anything that we can do to contribute to that evidence base and that knowledge, we are willing to do. Okay, so I'm going to shift gears pun fully intended, to talk about our latest investment program, the Shift Care program. So we recently released a RFR for a $10 million grant program. The Shift Care stands for Sustaining Healthcare Innovations That Foster Transformation. But the word shift is also an important nod to the aim of the program, which is trying to move care from hospital, institutional settings to community-based settings, or more appropriate or lower cost, as you might want to think of it, settings. And we put forth 2 tracks with known drivers of avoidable acute care use. So the first one is on social determinants of health. We received 11 applications for that funding track. The second track is on improving access to timely behavioral health care, another known driver of avoidable acute care use. We received 10 applications for that. We have a sub-track under the behavioral health one around increasing access to opioid use disorder treatment, and in that one, we're fairly prescriptive about what the intervention is. You have to induce medication-assisted treatment in the emergency department setting, and have appropriate partnerships with outpatient clinics and providers to continue that care. We were really delighted to get the most proposals for this particular intervention, and we had 15 applications for that. This, we were required by recent legislation to offer this grant program through our Distressed Hospital Trust Fund, but any hospital with an emergency department can apply. So it doesn't just have to be the charter eligible hospitals that could apply for this one. So for those of you who are really interested in data, here's some more data about the applications that we received. I'll point out 2 critical design parts of this program. One is that you have to have partners, and largely non-medical care partners. And so we were really excited to see the diversity of types of partnerships, and partnerships that actually had funding pass through to community partners from the ACO or the hospital or the ACO participant. And another important design component was the in-kind. And so we required proposals to have at least 25% in-kind, but some went beyond that, to have much larger full initiative costs. So we received a request for about $24 million for a $10 million grant fund. So it's we are in an embarrassment of great proposals, and we're working through the procurement process now. The plan is to come to the July board meeting with a recommendation about for around 12 proposals to fund over the course of those 2.5 tracks. So I'm happy to take questions on ACOs, PCMHs, or
All right, seeing none, that is the conclusion of the presentation that I had prepared for today. So, you know, we're at about an hour and a half. I'm you know, kind of open it up now to any questions or comments or suggestions, feedback. It's been a while since we've been together, so interested in hearing from you all. And I think,
Hey, Dave, thanks for those presentations. I just want to put this out there and something for you to think about, maybe talk with your board. There was a hearing last week, no doubt you know, on the nurse-staff ratio legislation, and it's not clear what the legislature is going to do about it. It could be a ballot question, and I testified on behalf of behavioral health to the effect that it would cost our system $173 million alone, and we would have to hire over 900 nurses. And I know the impact is much greater with the whole health system. To me, not even wearing my advisory committee hat, this is something that would seem obvious that the Health Policy Commission should do an analysis of, either health policy or CHIA, one agency from the state government, an objective analysis, so that the public would have this information and go to the ballot if it does in fact go to the ballot, and have some knowledge of what they're voting on, what the impact might be from an independent source. I mean, we have our numbers, of course, those would be challenged by others, but I think if there was an independent review, it would be enormously helpful to the public.
So know that people have some feelings on this particular. I would say this is something that we are consulting with our board on, and what is our role in potentially doing an analysis on what could be potentially could be a ballot question. It's not quite there yet in the process. So thank you for the suggestion.
Thanks, David. Just to follow up on David's points. Certainly, I personally, organization I represent, would welcome an analysis that you do. I'm quite certain. We did an internal analysis that had an 881 million, and then we had an external analysis that only went up to 1.3 billion, and we would lose 12 of the hospitals that take care of our most vulnerable residents. So my concern is that all the savings you talk about today, the idea that there's $5 billion of savings in this packet, that's gone. It's out the window because it's a $1.3 billion cost immediately, and then you lose those that are anchoring the system at the bottom. So, albeit a well-intentioned question, it will destroy the ecosystem of healthcare in Massachusetts. I hope you take it.
So obviously, we have a very different opinion of this, and I don't want to get into all this here. I've already made clear our opinion on this matter with you. We obviously would be in opposition of that. We think there are many things that the Health Policy Commission are to be working on now. This is not among them. I think there are plenty of stakeholders that will be putting forward their best efforts in terms of what they think the cost will be, as will we. And the debate will happen in the public, and that's really on the role of the HPC, particularly in light of the fact that the HPC is written right into the ballot and needs to maintain its stance as well as it has previously on the ICU. So we're very much opposed to this.
Brian, could I just comment on that? Just, sure. And not to debate, Julie was a friend. I would have, I guess, we welcome it. I don't know why everybody wouldn't welcome it, because it would be the most expensive deal that ever came before the Health Policy Commission. So if it came out that it wasn't going to cost any money, and I'm incorrect, I'll say, okay, I will live with the number that you come up with. It's just not possible. And so I think it is absolutely your charge and your role, because you are the one that look at costs of healthcare in the Commonwealth, and this will drive them up. So, well, so I guess my idea is that you will find it will drive them up significantly. I won't bury the lead and get to the conclusion before you have an opportunity to do your analysis.
Right.
So I want to suggest three non-nurse related things that for the industry to look at.
Thank you.
One is I'm so pleased that you guys are, the commission rather, starting to work on the social determinants issue, which is really a very critical issue. And I think there's a growing consensus that there's a strong case to be made that investing in social determinants reduces healthcare costs, certainly for the long term, even for the short and medium term. And one of the things that's going to be required to kind of see how well we're doing on social determinants is collecting data on that and tracking what's being invested and what's the return on investment, and what pays off the best, what doesn't. And so I want to throw that on the table as something, as a follow-up from the meeting that you're having in a few weeks, is making that a CHIA HPC process to look at social determinants. Secondly is the issue of drug costs. There's a lot of activity at the state level in different states. So Vermont last week just passed a bill to require importation of drugs from Canada. There's a lot of transparency initiatives in a lot of different states. And some of the national groups like NASHP have proposed state purchasing cooperatives, so statewide purchasing prescription drugs. I think doing some analysis of all those ideas, and there are lots of others too, would be really valuable for the HPC as part of their process of looking for savings ideas. And then the last thing I want to put on the list is oral health. We're so pleased that a year and a half ago, whatever, you guys did a little look at emergency room use, preventable ER use due to oral health problems. I think there's a real opportunity to look at the ACO and PCMH standards that as we go forward in time to include oral health and dental care as part of the responsibilities of ACOs and PCMHs, and doing some analysis there. A lot of, everybody understands that investing in oral health saves money on the medical care side, but yet our institutions don't put together the dental care and the medical care as one, and so there's some savings there too.
Great, thanks, Brian. Just a couple of quick points. One, on the social determinants of health, I think one of the things we're really excited about with the grant program that we're launching is, as part of that, is going to be an evaluation, and really part of that is continuing to create and build the evidence base that these investments can have a lot of these downstream savings and impact. So I think we hope to be able to continue to bolster that evidence. And on drugs costs, I just would highlight and note that one of our staffers here at the HPC, Sarah Sadownik, who works on our research and cost trends team, has been participating in NASHP. NASHP is the National Academy of State Health Policy working group on drug spending and drug costs for almost the last 2 years. And so it's been a great opportunity to be very keyed into what other states are thinking about in that area. So that's something that we've really been thinking a lot about as well. Ron?
So one of the problems is gathering the data. So as we look at population health, my big thing is that we're terrible at prospectively evaluating the risk of managing a given population. So, if there are communities in our region that if you gave me the pulmonary contract, I wouldn't touch it because I know that most of the people there smoke. There are other towns where nobody smokes, so those would be the ones you would take. And that's what insurance companies and other institutions do. So the fact that we did attribution after the fact of the ACO to undecided without that kind of analysis really weakens our ability to do this. So that may be why safety net hospital information went down because their performance is poor. The other appeal would be for cross-network collaboration. So at South Shore, we wanted to get licensed to manage networks. So in order to do that, we had to do a study. And that study required all of the groups participating in the CAT lab to work together to make sure we had low complication, high value. So that was the only example, other than bundled payments, where you can bring specialists together in different systems to get them to coordinate. So one of the weaknesses is that when you're in different systems, there's no incentive other than fee for service. You can get a ridiculous consult, and you do it in private practice. I spent half my career in academics, and I could call a resident and say, you don't need to do that consult. But in private practice, people don't do that. They just do the consult, put the money in their pocket, and walk away. So I think that ability to engage, given that we're so fragmented, we really need to find a way to do projects that allow specialists from different networks to collaborate.
Especially in specialty care, yeah.
So, I'm trying to formulate this properly, right? So MedPAC recently did an analysis of the Medicare Shared Savings Program, and most of the ACOs there lost money. There's various reasons why they were losing money. Worse in Massachusetts, I think we were probably a couple of years ahead of where the Shared Savings Program was in implementation and execution. I'm wondering, in addition to the series of policy briefs that you have, would it be helpful to actually do a bit of a comparison between the way we've set up our ACOs here and the way Medicare did? A little bit of is a lessons learned, because I'm sure Medicare's made some changes to their programs, but also I think maybe in an effort to help us in Massachusetts, because what would be helpful is what was the experience of those ACOs that are in Massachusetts under the Massachusetts program versus their shared savings programs? Were there similarities and dissimilarities? Where did it help and hurt? I think exploring some of that in detail may be helpful not only for us, but also for the rest of the country, in terms of especially if the trajectory of federal health policy is to decentralize, and the states are going off, doing various experiments. I think getting some lessons learned on the ACO side would be helpful for Massachusetts, particularly also in terms of if whatever we're doing is bringing the cost trend down. Is it more ACOs, or is it more this general notion of setting a target and all different parts of the system working together? Which one is it? Because a lot of folks think ACOs may not have been the silver bullet, right? And so, but maybe trying to explore how much they've had a role versus other factors. Maybe those are some ideas to think a little bit about for 2018. Thank you.
Yeah, we are, that's a great idea, and we're planning on doing something like that in brief 3, and this is getting to sort of a high degree of wonkishness right now that I think probably Marcy will appreciate when you start talking about financial benchmarks under ACO contracts. But of note, Administrator Verma yesterday came out and said, in light of what MedPAC found around SSP, that ACOs that just bear upside risk for like years and years and years, there are no savings. And so, the priority of the administration, it's also the priority of this administration. All Mass Health ACOs have to bear downside risk. And that's what, the AQC is, I think, but we still see a lot of upside only contracts for ACOs. I think what's hard and again, very wonky is that sort of the singular ACO can have multiple types of contracts. You can have a downside risk one for Medicare, you can have an upside only from TEPS, and so I think it's sort of trying to cut through and understand that variation and understand what's the evidence for everybody moving to downside risk. And we're gonna explore that a little bit in brief 3 and try to be as non-wonky as possible.
David?
So,
go ahead, Marcy.
So to build on Brian's on social determinants, I think one of the things you tackled at the cost trends hearings very well last year was this discussion that started, I think Kate Walsh said it very well, you know, it's gonna be the responsibility of the physician groups and the health system to take on what used to be called public health and public health spending, you know, are we the best ones to be taking care of housing and, you know, food insecurity and all of that. And so I think continuing that line along with the social determinants, because I think that question of who handles it best is really important, and we need to think about putting the money in the right place, so I build on that. And I think, Parashar, you were actually listening to my conversation yesterday with the Healthcare Transformation Task Force, because I think that Massachusetts and many other parts of the country have advanced ACOs, and if you look at the number of ACOs here that started in the Pioneer program, even if they didn't continue, folks like Makaipa, not just us, who've been in this for years, just are at a very different level. And so I don't know, Katie, whether you're able to distinguish sort of an advanced ACO by any set of measures, maybe not, but just thinking, you know, thinking about differentiators in terms of experience to see if over time that makes any difference financially. And then the other ones I would add to the list, one is oncology, which I think is a huge area of spend that as technologies continue to advance is going to be an increasing area of spend potentially. And also, again, sort of the academic medical center influence on the cost of it here in Massachusetts. The impact of demographic changes coming in Massachusetts over the next 10 and 15 years is huge, as the population is ostensibly staying pretty flat but aging, and so any kind of predictive analysis around how healthcare costs are likely to change based on aging alone would be really fascinating. And then the other area that really hasn't gotten enough focus, I think, is hospice and also the value that home health brings. So hopefully those give me some thoughts for what to do.
Thank you. Michael? Sure.
And I actually hadn't intended to talk about nurse staffing at all, but I'm prompted by the fact that we're your advisory council and we're supposed to provide advice. Sensitive to the timing issue relative to the fact that you have an issue on the ballot, I would note that there are serious questions were an initiative to pass that are worth discussing in terms of implementation at the right time. So I do think we're going to probably have to come back to, as a group, as a commission, or somebody at the state, in terms of questions both on quality of care issues as well as the cost issues that are interposed by the initiative on both sides. I think there are fair questions, pro and con, on the initiative. I raise it only because I think there will be a tendency for folks across the stakeholder groups to raise this increasingly over time. And in advance of a cost trends hearing a year and a half from now, I do think that there's a role, and it may be after the people speak on the issue, but it's certainly something that we'll need to come back to as a group at the right time. And so, you know, I don't want to sound wishy-washy, but I feel like we're dribbling the ball a little bit, but at some point we're going to have to face some of those issues together. And I don't see another group that could do it.
Well, and Julie mentioned this, but the ballot question, the initiative does contemplate an important role for the Health Policy Commission in implementing that, and some discretion in terms of regulatory development, and so it certainly would. Ron?
I think I applaud you on your sector analysis, but I think that, you know, we talk a lot about transparency. We spend a lot of time trying to cover, for instance, informing every drug on the market. Really, the drug pricing is non-linear. There's really a relatively small number of extraordinarily expensive drugs coming out of the market that can drive this. I think it would really be non-engineered. So, you know, we call it state variables. Those are state variables that we really need to get at. Because I think it's like self-insuring. You know, at South Korea, we have 4,000 employees. I think 24 were responsible for 60% of the budget when they look at self-insurance. So that's something that I think would be very helpful.
Yeah, and that's certainly from some of these other states that have been doing drug transparency, there's kind of many of them have this idea of kind of the big cost drivers, really a focus on those particular classes or specific types of drugs. All right, well, I think I'm gonna adjourn this meeting. Thank you all for your advice and counsel, and look forward to another great year together. So we'll be in touch, be in touch with us, and have a great rest of the day. Thank you.
Thank you.